Well, welcome to another episode of the Osteopathic Lyceum podcast. What I want to do today is essentially attempt to expand on things that I've pointed to and be as explicit as possible. So if you've consumed some of the stuff from the YouTube channel, which is the Osteopathic Lyceum, and you've looked specifically at the assessment playlist, one of the things that you'll notice is that I point to a concept that I call macro identifies micro. Stated otherwise, that large motions in the human body are made up of smaller subcomponents. And those smaller subcomponents, if the large movement does not work properly, there is a smaller subcomponent or subcomponents that are not functioning as they should, and they're usually visible. So first, what I want to do is point to the rationale for using that heuristic or using a heuristic at all. Now, again, I would have pointed to this if you've consumed previous material. You've heard me speak about this. So the definition that I use for heuristic is an old one, and it relates to one that I like. It doesn't mean it's the most accurate or useful definition of heuristic, but it's the one that I'm utilizing. So to be clear, it comes from 1985 and artificial intelligence research in 1985. It differentiated between an algorithm and a heuristic. So an algorithm is a set of steps that guarantees a solution, where a heuristic is a set of steps that generates possible solutions, at least in that framework. Now, the reason that the definition that a set of steps that generates possible solutions is one that I prefer is that human beings, while having the same rough architecture, so we're all similar enough to one another that we're all categorized as humans. However, we're all different enough that we're identifiable as different. So to generate a definite solution with an algorithm is a problem because there's enough variation that the people are not the same, such that, at least in concept, a heuristic generating possible solutions allows for more accurate application to the individuals present because they're different. All right. So guaranteeing a solution is likely inappropriate because humans are not, we're the same enough, but we're not the same. We are different enough to be identified as separate from one another. So a set of possible solutions to test through, to experiment through, will be more accurate than something that can be conceptually seen as a guaranteed solution. Hopefully that makes some sense. So maybe more simply saying, humans are not the same. So if we use a set of steps that generates possible solutions, we can figure out the best solution for the human or humans involved. So the practitioner being one of the humans involved and the patient being one of the humans involved, generating the best or generating a set of possible solutions to work through to figure out and maybe combine which works the best in that circumstance versus a set of steps that guarantees a singular solution likely is inappropriate. Okay, so we use a heuristic as an intangible concept that can be applied to tangible things. This relates relatively well to far transfer in education settings. So far transfer is essentially the context, the initial learning context and the application context are quite far apart, especially superficially, such that the only thing that's the same is what would be called a deep feature. There's no agreed upon definition of what a deep feature is, but a deep feature would be something that's non-tangible. So it is a concept that connects things, right? So it's causal plots in a story, or sorry, like plot, like a story plot, or causal mechanisms, things that you can't see, things that you can't touch, but things that are the same between circumstances. So utilizing a heuristic because it is the same between different circumstances conceptually maps well to far transfer. Now, far transfer being useful because the particular presentation of a patient may be different for, say, the same underlying thing, or the superficial presentation may be the same, but the underlying thing is different, right? So you've got to be able to figure that out, which is why a non-tangible concept likely applies better. So the use of a heuristic is not just because humans are different, but it's because circumstances are different, and it also relates well to what we understand about the ability of an expert to import a concept in one circumstance versus another and connect them in a meaningful way. So heuristics are useful not just because of normal variance, so having a set of possible solutions being useful for normal variance between circumstances, but it also relates well because the heuristic itself is guiding. It's a non-tangible concept that can be utilized in very different circumstances. So it again relates well to what we know about the ability to apply a skill in a multitude of circumstances. So these things sew together fairly well. Now, it's not to say that they're perfect, it's to say that this is utilized based on best available evidence right now, which can alter over time. And if it does alter in a meaningful way, we'll obviously attempt to shift how we're delivering all of this information. Now, so we've got a heuristic, or we've got assessment heuristics, right? So the assessment heuristics that we have or that we put forth are patient active before patient passive, preferably, right? It doesn't have, you don't absolutely have to, but it is very useful to use patient active tests. Now, one of the things that using patient active tests ends up being extremely positive for is that hands-on practitioners in personal experience have a very strong penchant for shortchanging their tests. So it's often observable, at least superficially, not necessarily meaningfully, but superficially, that there's some predetermined preference based on a static visual assessment for motion. So if the right shoulder is low, then they'll say you're right side bending through some region. And then when they go and do a hands-on test, what they do is they'll impart more force to generate right side bending and almost no force to generate left side bending. So it's like they're confirming their visual finding. However, if you use a patient active test and ask the patient to move as far as they can into right side bending and left side bending, the difference will be notable, at least to the degree that the patient is willing to bend one way versus the other. Now, if they're willing to bend as far as they're capable, then there could be discomfort and you'll see winces, right? So that's a good sign that one side is more uncomfortable than the other. But also, if they engage as full a range of motion as they're able or willing, then you start to notice essentially safety cues. So maybe they bend farther one way than they were willing to bend themselves, but that's where you can identify the difference between passive, or rather active and passive. But if a patient bends this far and the practitioner bends them this far, then you can see that the practitioner is shortchanging, right? So you have some opportunity to compare. So your active tests rather are very useful for safety, right? So to know how far the patient is comfortably willing to go. So if you go farther than that, you're running risks. It is a very, very rough screen for motor nerve function as well as general soft tissue function. So if there's a tear or a break, somebody probably won't move at all, or they can't move in a particular direction. And if there's a motor nerve dysfunction, also the same thing would occur. They can't do it. You'd have really strong reason to understand that either one of those was present prior to assessing the patient. But if it shows up and it's really old and the patient has kind of ignored it, you might run into the circumstance where you ask for a movement and it doesn't occur at all, and then you need to refer out. But for the most part, patients who bring themselves to a private practice that's run on a schedule likely is not in an emergent situation. So it's less likely that you'll run into that. Not impossible, but less likely. So then the most important part of the patient active test is to note how far the patient will move themselves. And then you can figure out, if you're observing another practitioner, if they're shortchanging the test. And if you're observing yourself, you know if you're shortchanging the test, because if you don't even go as far as the patient went themselves, then you're missing lots of stuff. All right, so patient active before patient passive is good for safety, but it's also good to figure out if you're shortchanging stuff. The next heuristic we already discussed as an example is macro identifies micro, or large motions are made of smaller subcomponents, and if the large motion isn't working, you can usually identify visually the smaller subcomponent that is not working. And the final one is be organized. So start in a particular place, go in a series to another particular place and another particular place and another particular place, and end in a specific place. So you start in one place and you have a consistent progression through your testing regimen to end at a specific spot. So being organized. Now, being organized means that you can automate a lot of the testing. You think far less about it in its application, which means that when something's wrong, it's much easier to notice, because everything's going fine, and then you do this particular test and something's wrong, it's easier to remember, so you drop your cognitive load, right? So we've got all of this going together as heuristics or as non-tangible concepts that will be the same regardless of context. Now, being organized, just to kind of move backwards for a moment to make a specific point, is to say that as often as you can do the same tests in the same order, in the same way, you'll increase internal consistency, which will increase so within yourself, rate or reliability. So you are likely to generate a stable range of findings when you use the same tests in the same order in the same way. So it's more trustworthy. Now, if somebody else is testing in different ways, then your reliability between yourself and the other practitioner is going to be poor. That said, you'll likely identify similar areas that have restriction as long as you're not shortchanging your tests. Okay, so we've got a bunch of heuristics or non-tangible guiding concepts that are same in different circumstances. They can be imported. So then what you can do is if you can't do a particular test, then you can substitute another one. Or maybe if you can't do a particular test in your normal test bank, that maybe this is a patient that should be referred out for further assessment by a radiological professional or some other test. But you get a really good sense because you're consistent. You know whether or not it's safe to do something or not. So we've got our heuristics. We've got a reasonable grounding based on best findings as they currently stand as to why we do that. So we can refer to general osteopathic literature as far as assessment is concerned. Rate of reliability is generally not that good, aside from if people are trained to do the exact same test the same way, then tissue texture changes can get to decent levels of inter-rater reliability, as can tenderness or pain provocation. So those can get to decent levels of reliability between practitioners if they do the same test the same way as one another. When you don't do that, maybe it's not as good. The ability to accurately identify structures is not the best, right? It is highly variable amongst experts, especially with smaller bones. It's not that hard to identify the humerus. It's not that hard to identify the clavicle, but we're talking about smaller landmarks. So things such as the posterior superior iliac spine, things such as the superior sacral sulcus, or poles, however you want to say it, the spinous process of a specific lumbar vertebrae. Those are not the easiest for accuracy. So we want to be careful when we talk about accuracy because we want to make sure that it's obvious that we're talking about more obscure landmarks. Now, more obscure landmarks are further obscured or highlighted depending on general body composition. So the leaner somebody is, it's easier to find more obscure structures. The less lean somebody is, the harder it is to find more obscure structures. So we start to identify that claims of accuracy in identifying structures, especially obscure ones, is not the best. So maybe we shouldn't do that. If we're relying on static landmarks, we could just be making commentary on the shape of a bone. Bones are roughly symmetrical, but not actually symmetrical, especially when paired within humans. So if you're simply looking at asymmetry, you might just be noticing the different shapes of bones where you're able to identify them. If you're looking at differences in motion, then you have both a quantitative and a qualitative measurement. Now, obviously, there's a degree to which it's subjective, but if you do the same test the same way consistently, then your reliability improves. If you acknowledge that you can't shortchange your tests and you do a patient active test first, followed by a patient passive test, the reliability is it is predictable that your reliability and accuracy would go up as far as motion is concerned, or identifying motion restriction, or identifying motion asymmetry. This has likely not been studied appropriately because that's not the approach that the profession has taken so far. It doesn't mean the profession's incapable of it. It just means it hasn't happened yet. So if we're synthesizing the information about assessment so far, we note in the literature that reliability and validity of osteopathic assessments are not great. So if we look at how they're done, and look at other contexts, we can improve that, which is why I put forth the heuristics that I do, such as patient active before patient passive, macro identifies micro, and be organized, right? Those help you deal with validity Now, validity being a test is testing what it says it is. So if you're testing asymmetry and saying that something is, or if you're testing static asymmetry rather, and you make a claim about dynamic asymmetry, it's an invalid test. If you test the levels of PSIS and the patient is static, and you say that the right PSIS is superior, that is not valid. However, if you rely on motion, because you acknowledge that while human bones are roughly symmetrical, they're often asymmetrical enough to be identified as different. So you essentially don't focus on the static asymmetry, you focus on the dynamic asymmetry, and you note gross motion differences, macro identifies micro, and you point to the area that it's visually most restricted, and you say nothing further than that. You don't say it's this ligament, it's this bone, it's this muscle. So you remove your accuracy claims. You just point to the area and say that's where it is the most restricted. Then you're going to have a predictable opportunity to be much more valid in your claim, much more valid in your accurate identification of where something's not moving. You're not making a claim on the layer of the tissue, you're not making a claim on the structure, you're just saying it's there. Your validity increases by doing the exact same test, just removing your accuracy claim. If you do the same tests in the same order, the same way, consistently, your reliability increases because you're not going to have one finding, you're going to have a consistent range of findings. Now, it may not necessarily translate between yourself and another individual if they do different tests in a different way, consistently or inconsistently. So interreliability is still a problem, but at least as an individual practitioner, your reliability can increase. So we know that reliability is a problem in osteopathic assessment. We know that validity is a problem in osteopathic assessment. You can do the exact same tests and just change how you're making your claims and how you're interpreting your findings. And this is why we use the heuristics that we use. Again, we're leaning into transfer literature or transfer of learning from one context to a considerably different context. So you could say that the considerably different context, or maybe subtly different contexts that are hard to identify, is different people, right? So they may be subtly different, but the difficulty in differentiating between them is hard, right? So that it's not the easiest argument to make as FAR transfer, but it's an argument to be made for at least transfer and something that is difficult to be tangible or identifiable, right? So FAR transfer is a reasonably decent framework for this, especially on account of the fact that the patients will have different issues, right? So the deeper you try to interpret a movement finding, the less valid you have the opportunity to be because you're working from an external environment of observation. You're outside the patient. You can't see deeper than the superficial layers, right? And you can interpret, and sometimes you can be reasonably accurate, but it's just not consistent that you'll be accurate as to what muscle, what nerve, what ligament, what tendon, right? It's harder. So if you just say it's not moving there, right? What region? This region. Then your validity increases while doing the exact same test. So you're just changing your interpretive step. So another thing that we want to consider that will make it harder to be valid is a concept called degrees of freedom. So there's a way that you can use degrees of freedom colloquially. It's just like how far can something move, right? That's just a really simple thing. But degrees of freedom is essentially I think it's the appropriate definition is the minimum amount of points required to describe a motion is the degrees of freedom, right? So within a given plane, you can have translation, right? So if you consider a three-dimensional system, you can have translation forwards and backwards, upwards and downwards, and left and right, more or less. So that's 3 degrees of freedom. So you would require a point on each one of those axes to describe a motion because it might translate that way. Then you have rotational degrees of freedom. So rotation in the coronal plane, rotation in the sagittal plane, and then rotation in the transverse plane. So you have flexion, extension, side bending, rotation as 3 degrees of freedom. But because translation is at least possible, because some of these joints can slide in relation to one another, then you can have the anterior, posterior, superior, inferior, and lateral translations as well. So you need 6 points or 6 degrees of freedom to describe the particular motions. The translation is minimal in most joints unless often acted upon by an external force. So a practitioner can translate a joint better than a patient can. But the patients can translate their joints to some degree that is not immediately identifiable to the practitioner because they can't see the joints. They can see the gross motion. Because there's 6 degrees of freedom and they are going to be difficult to identify for the practitioner, you're not going to be as specific as you want to be. If you minimize the degrees of freedom you're looking for, and you're looking for more gross asymmetry, larger asymmetry, macro asymmetry that can be identified in a region or a particular subcomponent, you're reducing your cognitive load and you're increasing your accuracy because you're minimizing the degrees of freedom that you're checking, which is why in most cases with the vertebral column, at least the thoracolumbar column, I check side bending. So I check essentially rotation in the frontal or coronal plane. So side bending left, side bending right. There's a consistency to that for me because I very rarely find a true bilateral dysfunction. I rarely find a dysfunction in flexion and extension. Also, flexion and extension are biased in most positions. So the table is either in the way or when the patient's seated, they're in relative hip flexion, which alters some of my findings. Also, when people flex in a seated position or in a standing position, they'll often run into their abdomen regardless of how lean they are. So there's a physical blockage or a soft tissue approximation blockage. So I find there's a lot of noise in flexion extension. I also find there's a lot of noise in rotation because visually there's so much happening. The shoulders move more obviously and they will obscure the vertebral column because it looks like the vertebral column is more or less in the same place. So it's harder to interpret, at least for me. For other people, that's not going to be the case. They're going to be quite accurate with rotation. So I use side bending because I just want to know which side the dysfunction lives more so on. And that helps me control my findings and my results much better. Doesn't mean that everybody else has to do that. But if you are leaving a completely open landscape and trying to identify 6 degrees of freedom, the translations in all 3 planes and the rotations in all 3 planes, you have way too much to think about, and you probably can't identify it accurately. So we minimize the degrees of freedom that we're looking for in many cases, not all cases, depending on the particular joint and circumstance. You may investigate more degrees of freedom, especially when treating more than when assessing, because you can assess in, say, a minimized range or a minimized amount of planes or in 1 plane, depending on the circumstance. But when you treat, you're being much more subtle and detailed in your approach. So you might find some other stuff that you didn't find in your large test because you can be much more detailed when you're hands-on and in that particular area because your hands are really good at identifying resistance to motion, either in soft tissues or in joint play. So you can get much more detailed in the treatment, but in the assessment, you minimize the degrees of freedom to minimize cognitive load and to increase consistency and to increase accuracy, right? So you don't necessarily test all planes all the time because there's a lot of redundancy. You've identified where the major restriction is often by testing 1 plane. You can choose the plane, but the way that I would suggest figuring out which plane to test in is you test all planes all the time until you figure out which planes don't give you much information or much control over your results, and then you remove those, right? Remove 1, remove 2, do it how you see fit, but be purposeful and be organized about it. And that's how you build your consistent, stable assessment that you do to everybody you can do, and those who you can't do it to, you don't, or you can't do test A to somebody, so you bring in test X, whatever it happens to be. So that's kind of the rationale for why I build the heuristics, because the heuristics give you a set of possible solutions. The heuristics also are a concept that is non-tangible that can be transported across circumstances to be applied accurately. So you have a building block to work from. So it works really well for how cognition works and how transfer works, right? And then to be organized and to be cognizant of issues with accuracy and validity and with reliability or consistency, right? We take all these disparate pieces of information and we build the framework with which to practice. So those are the rationales for why I'm making the suggestions that I'm making. So if you look through the YouTube catalog at the assessment playlist, you'll understand at least that portion better. Now, the same basic rationale applies to all of the other playlists and all of the other heuristics that I put forth, because there's many others, but it's the same basic rationale that applies across these contexts. So hopefully you find that useful, and hopefully there's some way in which at least hearing this, as opposed to seeing it demonstrated, helps you wield those concepts a little bit better and apply them to your own setting.